Hi, can see ne?
Yes, sir.
Okay. Sorry, yeah, there seems to be something wrong today, bro.
That's
Technology
okay.
problem. Technology problem.
Alright.
Okay, hi, fine. Okay, so we discussed this one, and we were talking about gastroesophageal reflux disease. Now, this is very important because this is a very important complication of gastroesophageal reflux disease. Now, all of you know what this is because of long-standing reflux. This is essentially Barrett's esophagus, Barrett's esophagus, where you can have a sort of extension of the columnar lining, or there is intestinal metaplasia of the esophagus. Okay. So actually what happens is this can predispose to adenocarcinoma of the esophagus and not squamous cell carcinoma of the esophagus. It's a lower third of the esophagus that you get adenocarcinoma. Now, the last thing is also important to appreciate. 24-hour pH monitoring of the esophagus is essential for diagnosis. You can diagnose gastroesophageal reflux predominantly clinically, right, using the clinical manifestations. Sometimes when the gastroesophageal reflux becomes difficult to control with medication, we sometimes use a pH monitoring, which the trace looks something like this. pH monitoring to assess how bad it is, and also these sort of patients you would refer for more intensive invasive interventions. Right? So it's not essential for diagnosis, but it is something that you do in patients who do not respond to medication. And remember, you can diagnose GORD predominantly on a clinical basis. Right. Okay. So that's quite a simple MCQ. If you have any questions, please ask. Chat I will discuss that. Right, now the next MCQs are focusing on peptic ulcer disease and Helicobacter pylori. So initially we have a few facts about Helicobacter pylori. Now, Helicobacter pylori is the most common cause of peptic ulcer disease. Most common cause. Now, as you know, peptic ulcer disease refers to duodenal ulcers and gastric ulcers. The peptic ulcer disease. Gastric ulcers, duodenal ulcers. But remember, up to 95% of duodenal ulcers are due to Helicobacter pylori. So if you take duodenal ulcers, 95% is due to Helicobacter pylori. Gastric ulcers about 70 to 80%, because remember there are other causes of gastric ulcers, for example, NSAIDs. But Helicobacter pylori infection accounts for a large majority of duodenal ulcers. Right. Another very important thing to remember, Helicobacter pylori infection is traditionally, or actually was traditionally reported in overcrowded communities. So the incidence is data, but there is a very strong association with poor socio-economic status and overcrowding. Okay. Hello?
So there was a bit of a disturbance.
Yeah, there is a bit of a problem. That's fine. Okay, so Helicobacter pylori infection is traditionally associated with poor socioeconomic status and overcrowding. And this is because this infection spreads via the fecal-oral route also. Right? So that's why it's traditionally associated with overcrowding and poor socioeconomic status. So and this map shows evidence to that. Right? Poor socioeconomic status. Association. Right. Of course, you do see it in other parts of the world like Australia and UK also. But traditionally, one of the major risk factors for Helicobacter pylori was noted to be poor socioeconomic status. Now, the second point in this slide is also very important. You should know apart from ulcers and gastritis, what are the other associations of Helicobacter pylori infections? Associations and complications of Helicobacter pylori infection. Now, these are gastric cancer, malt lymphoma. So there is association with gastric cancer and gastric malt lymphoma, right? Gastric malt lymphoma. So remember these things. Okay, so in this MCQ, we talked about this associated with poor socioeconomic status, considered a causative agent for gastric malt lymphoma. Now, if you take the organism itself, Lamai, there are a few facts that you need to know. Helicobacter pylori is gram-negative, and it's found in the very deep mucosal layers, right? So, if you imagine the mucosa is a thick layer, right? All the mucosa, it's deeply embedded in the mucosa, right? And it is attached in some cases to the gastric epithelium, right? So, it's very deep in the mucosa and is attached to the gastric epithelium, right? And most of the time you find Helicobacter pylori in the antral region of the stomach, right? So it's deep in the gastric mucosal gel attached to the gastric epithelium. And the interesting thing about this organism is that it produces urease, right? Which breaks down urea into ammonia. And that ammonia gives a nice neutralization of the hydrochloric acid. Right? So the ammonia nicely neutralizes the hydrochloric acid around the organism, and that helps the organism to survive. Right? That helps the organism to survive. So urease is an important thing that this organism produces. Additionally, it also has various other antigens, adherent various antigens also, like CAG-A is an example, and BAC-A. Right? So various pathogenic antigens are also present in these organisms. Right. Okay. So facts ටික මතක තියාගන්න ඔය MCQ වලට අහනවා. Sorry. So these things we have already discussed now. So we said that commonly found in the antrum of the stomach, right? But a gram-positive bacillus. Right? It's a gram-negative bacillus. Yes. So yes, Helicobacter pylori can increase gastric acid secretion because it depletes somatostatin. ඒක පොඩි complicated mechanism එකක් තියෙනවා. එහෙම ආවොත් ටිකක්. Okay. Right. So how do you diagnose Helicobacter pylori infection? There are methods. You have surgery, that endoscopic methods. Endoscope එක කරලා you can take a part of the course up and then test කියලා තියන්නේ. ඒකට දැම්මම පාට වෙනස් වෙනවා. Right? පාට වෙනස් වෙන, and the mechanism there is just the presence of urease in this organism. Right? That's how the color changes. So flow test, and I've given a picture on the left. Of course, other endoscopic, it's like testing the stool antigen. Sorry, the internet kachalla mai, I don't know why. Somehow you can hear me again.
Yes, sir. Can I hear? Sometimes it breaks, but it's okay.
Right. So slide එකක් පේනවද? Or has that also gone now?
Slide is not visible.
Not visible.
Okay, so slides.
Right. Okay, let's try our best do this. Yeah. We issue and do a flow test, which is again we test the presence of urease in the organism. Right? That's what it does. That's a base. Right. So let's do the MCQ then. Right. So make ඉවර කළ දාමු associated poor socioeconomic status is true. Gram negative bacillus maker, antrum of the stomach.
So we had a problem at the end also.
Yeah. Okay now?
Yes, sir.
Right. Right, you can see the screen, eh?
Yes, sir.
Yes, sir.
Right, okay. Okay, right. So antibody testing is not the gold standard. What we currently use is stool methods. Right? Sometimes we use the urease, the urea breath test. It's not a very the urea breath test is not often used, but the stool antigen and the endoscopic methods are the ones that are commonly used. Right. Okay. Let's go to question 3. True or false regarding. So Sajid's histology is the gold standard for diagnosing Helicobacter pylori, but that's not a flow test. Those all things are the ones that we do, right? But histology is supposed to be the best, but we don't do it often. Right? Right. Okay. Fine. Hari. Now, the third again on peptic ulcer disease. So the first statement is more than 95% of gastric ulcers, the gastric ulcers are due to Helicobacter pylori. Most often, it is the duodenal ulcers that are associated.
Excuse me, sir. Sir,
Yes.
it's still here. Like the connection is not clear, sir. Sir, will it be okay? Like if we can do it without the screen sharing, maybe we can.
Wait, I'll try to see if I can change my location and see something like. Now can you hear now? Is that better or worse?
No, sir, still.
Sarah, can you?
Still, it's a bit,
yeah.
So since we have the slides, we can do it.
Yeah, the previous times it just happened. That doesn't really help, but we'll try.
Okay.
Right. Right. Okay, fine. Some days this happens. I don't know why, but yeah. Okay, come on. Where is this? Okay. So the third MCQ then is yeah. So peptic ulcer disease, okay. So the second statement there is recurrent duodenal ulcers are a recognized feature of Zollinger-Ellison syndrome. So Zollinger-Ellison syndrome is essentially a gastrinoma, and that is associated with duodenal ulcers. Right? Endocrinology, but I've just put it here because it's related to peptic ulcer disease. Now, actually, if you take the clinical presentation of peptic ulcers, gastric ulcers versus duodenal ulcers, there's a slight difference in how they present. Okay. This is not always true, but you can sometimes differentiate this. Now, classically, gastric ulcers are worse when you eat something. Gastric ulcers are worse. The pain gets worse when you eat something. Whereas duodenal ulcers are typically seen when you're fasting. It becomes worse when you're fasting, and especially at night. Now, this is not a hard and fast rule, but sometimes you can see this pattern. Right? So duodenal ulcers, mostly the pain gets worse on fasting and also during the night. Okay. Right. Now, the next thing that we need to talk about is how you would manage peptic ulcer disease. Right? The management of peptic ulcer disease. Right. Now, if you go to slide number 11, got a calling slide digger, right? Okay. Now, peptic ulcers are usually treated with proton pump inhibitors, right? Proton pump inhibitors. That is now currently the best recommended therapy for peptic ulcers in general, proton pump inhibitors. Now, what proton pump inhibitors do is they inhibit the H plus K plus ATPase in the gastric cells, right? And they actually irreversibly inhibit H plus K plus ATPase. Right? That is what they do. So for most peptic ulcer disease, what you do is you give them a proton pump inhibitor. That is currently the standard of care, standard drug that we use. However, the story, the story is different if they have Helicobacter pylori infection. Right? Then the story is different. Right? So if they have Helicobacter pylori infection, then you would treat them with Helicobacter pylori eradication therapy. That is the important thing to remember. Right. Right. So in the UK, we don't do this often in Sri Lanka. Anybody with peptic ulcer disease, they test for Helicobacter pylori. Right? They test for Helicobacter pylori. If they are Helicobacter pylori positive, you treat them with Helicobacter pylori eradication. If they are Helicobacter pylori negative, simple measures like just a proton pump inhibitor for 2 to 4 weeks should be adequate. Then, before we move on to the next MCQ, podi කාරණයක් තියෙනවා මතක තියාගන්න මෙතන. මේක තරුවක් දාලා උදේට ලියා ගන්න slide 11 වල ළමයි. Saranga, is it better now? Can you hear better now?
Yes, sir. It's much clearer.
Hari. Okay. Right. Just follow the slides as I tell you. Okay.
Okay.
So the standard way is fine. You have peptic ulcer management. Summarize standard way. You have peptic ulcer disease. Try to do a Helicobacter pylori test, stool antigen right, or a urea breath test, and you diagnose Helicobacter pylori. If there is Helicobacter pylori, treat as Helicobacter pylori. If it's negative, don't have to worry. Treat with proton pump inhibitors. Now, MCQ point remember, if you have Helicobacter pylori negative, right, you are quite sure you can act here, right? Because there is a very good negative predictive value in these tests of more than 95%. So Helicobacter pylori negative test, either endoscopic or non-endoscopic, you can be damn sure that there is no Helicobacter pylori. And මෙන්න මේක MCQ වලට අහන මේ තුන්වෙනි පෙට්ටිය ඇතුලේ තියෙන එක, right? You only retest. So එකපාරක් කළා negative නම් you just forget about it. you only retest if they have any of these conditions. Ek conditions tika MCQ වලට අහන්න පුළුවන්. So these are the only indications for retesting for Helicobacter pylori if the initial test is negative. Right? So duodenal ulcers තියෙන එක හරි especially family history of cancer, maltoma, so malt lymphoma කියලා අපි කිව්වේ, right? Or if the test was performed within 2 weeks of PPI or 4 weeks of antibiotics. Right? So ඒ වගේ වෙලාවට විතරයි අපි retest කරන්නේ ඕක. හරි? Okay. Right. So that's important. Okay. So go back to question number 3 then. So fourth statement, irreversible inhibition of H plus K plus ATPase. Yes, that's right. Okay. Okay. And this is the treatment of Helicobacter pylori. Right? There are commonly used drugs, triple therapy. Triple therapy. So if they are positive, you treat them with triple therapy. Right? Triple therapy is commonly used combination is a proton pump inhibitor with amoxicillin, clarithromycin, or metronidazole. Right? So amoxicillin, clarithromycin, or metronidazole. So you have a choice between clarithromycin and metronidazole. Right? So usually 7 days therapy is adequate. Usually. Right? මෙතන තියෙනවා penicillin allergy තියෙන අයට මොනවද දෙන්න අරක මේක මගුල් ඒව වැඩක් නැහැ. Just remember triple therapy, PPI, amoxicillin, metronidazole or clarithromycin. That is it. Right. So remember, without a clear confirmation of Helicobacter pylori, please do not give Helicobacter pylori eradication. එහෙමත් MCQ එකක් අහන්න පුළුවන්. If there is, you do not give triple therapy unless there is clear evidence that there is Helicobacter pylori infection. Right? Okay. Right. Hari. Any questions now about GORD and peptic ulcer disease? මොනවද ප්‍රශ්න තියෙනවද?
duodenal ulcer එකේ මේ H pylori එක අපහු බලන්නේ ඒකේ ulcer එක අනිවාර්යයෙන්ම H pylori වෙන්න ඕනේ කියලා අපි හිතන නිසාද?
Oh, ගොඩක් වෙලාවට එහෙම නිසා. So it might be rarely falsely positive because most of the time it is due to Helicobacter pylori. ඒ නිසා නැවත කරන්න වෙනවා. Yeah. So maltoma කියන්නේ malt because Helicobacter pylori is strongly associated with malt lymphoma නේ. හරිද? ඒකයි ඒ පූර්ණ. අපි කිව්වේ one of the common associations. Okay, right. So go to question number 4 then next. Right. Now I think 4 is based on infection, right? Acute diarrhea. Now whenever infection ගැන කතා කරනවා when we're doing infectious disease as a set of MCQs, but I have just included it here because we are talking about acute diarrhea in gastroenterology. Right? So just one statement, one MCQ on acute diarrhea. Method. So let's just go through this. We'll revisit this when you are doing infections. True or false regarding acute gastroenteritis? Shigella causes dysentery. Shigella causes dysentery. So remember, dysentery refers to blood and mucus diarrhea. That is what it refers to. Dysentery can be due to certain special organisms. Right? What are the special organisms? Number 1, Shigella. Number 2, certain forms of E. coli which are more invasive. So invasive forms of E. coli, Shigella, and amoebiasis. These are the ones that cause dysentery, blood and mucus diarrhea. Right? Dysentery. So Shigella is very common. Amoeba and also E. coli, which are the more invasive, aggressive E. coli strains, can cause dysentery. Right. And if you look at slide 15, that sort of gives you a list of all the various types of E. coli. අපි මේක ආයි කරනවා ඒ නිසා කලබල වෙන්න එපා. හරි? Okay. Right. Now the next MCQ statement is on salmonella infection. Right? Salmonella. Now as you know, salmonella can cause typhoid fever. පොඩ්ඩක් ලියාගෙන අපි ආයි මේවා කරනවා. නමුත් පොඩ්ඩක් මෙතන MCQ තියෙන නිසා අපි ලියා ගමු. So salmonella causes typhoid fever, as you know, but there are lots of other strains of salmonella which I call non-typhoidal salmonella. Non-typhoidal salmonella. Now, if you take typhoid fever, you should know the complications of typhoid fever. Complications of typhoid. What are the complications? Typhoid fever, as you know, can cause intestinal perforation. Intestinal perforation. That is a complication of typhoid fever. You also know that the typhoid bacteria, salmonella, can go and live in the gallbladder. And you've heard of typhoid Mary, right? So this typhoid organism can go and live in the gallbladder and can sometimes present with cholecystitis. Cholecystitis, right? Cholecystitis. So intestinal perforation, cholecystitis. It can also cause rarely a sort of an encephalitis picture as well. Right? Salmonella can rarely cause an encephalitis picture. Right? So we'll talk about typhoid in more detail in infectious disease. Okay, right. Now, about Campylobacter causing acute diarrhea, few special things to know, MCQ points. Campylobacter is acquired commonly by sort of dairy products, poultry, right? Campylobacter. Poultry and chicken, right? And all of you know Campylobacter can trigger post-infectious Guillain-Barré syndrome. Ekat important MCQ point. Hari. So in this table, I have given you the various strains of E. coli. 15. Slide 15 wala mama E. coli strains ඔයගොල්ලන්ට දීලා තියෙනවා. ඒකේ so in this MCQ you are asking enterotoxigenic E. coli නෙවෙයි enterohemorrhagic E. coli. EHEC කියන එක තමයි HUS හැදෙන්නේ, right? And that's O157 කියන strain එක. O157 කියන strain එක. So that is false. O157 enterohemorrhagic E. coli is the fellow that causes a HUS picture. Right. Okay. Then obviously in acute diarrhea, one of the main treatment options is ORS. Okay. So we'll do this again. We'll do this again when we do infection. Now, MCQ 5, number 5, chronic diarrhea. Chronic diarrhea, slide 17, right? Now, when you have chronic diarrhea, what you usually say is chronic diarrhea is diarrhea lasting for more than 6 weeks. Right? Standard. But most people agree that it is diarrhea going on for more than 6 weeks. Right. Now, there are various ways on how you approach chronic diarrhea clinically. One of the, so if you look at slide 17, slide 17, chronic diarrhea can be categorized clinically into small bowel chronic diarrhea or large bowel. So that is based on an anatomical approach. Anatomical approach checking right? So small bowel diarrhea or large bowel diarrhea. Now, small bowel diarrhea has a lot of water in it, because a lot of water in the diarrhea. So they are usually large volume watery stools, right? When there's small bowel diarrhea. Small bowel diarrhea. And especially, at least note this, when the distal ileum is involved, because that's where all the fat and fat-soluble vitamins are absorbed, they have steatorrhea and fat-soluble vitamin deficiencies. So small bowel diarrhea generally more watery, but when the diarrhea is due to a distal ileal disease, they have steatorrhea, right? That's more fatty diarrhea, right? So fatty diarrhea, and also they have fat-soluble vitamin deficiencies, ADEK deficiency. Okay. Now, as you know, a lot of the nutrients are absorbed in the small bowel. So if they have small bowel diarrhea, they get malabsorption, lot of nutritional deficiencies, lot of nutritional vitamin deficiencies, protein malnutrition. So they have malabsorption, vitamin deficiencies, and other nutrient deficiencies when they have small bowel. Then make a MCQ එක ලේසියෙන් අහන්න පුළුවන් දෙයක්. Differences between chronic diarrhea, small bowel, large bowel. So small bowel, you know, more water, distal ileum steatorrhea, and fat soluble vitamin deficiency. They have clinically lot of nutritional deficiencies because a lot of the nutrients are absorbed in the small bowel. So anemia තියෙනවා, various vitamin deficiencies අරක මේක ගොඩාක් කතන්දර තියෙනවා, problems. Hari? Okay. And sometimes small bowel diarrhea causes pain which is referred around the umbilicus. Small bowel referred pain in the umbilicus. So that is around the umbilicus. Right. So this table is very important for MCQ. So large bowel diarrhea is different. There's a lot of mucus. In large bowel diarrhea, there's a lot of mucus, and it's not a large volume, but there is mucus. And the most important feature about large bowel diarrhea, especially when the rectal region is involved, they get tenesmus. And blood is much commoner in large bowel diarrhea. Blood and mucus is much more common in large bowel diarrhea. And as you know, the large bowel diarrhea pain is referred to the hypogastric region. Large bowel pain is referred to the hypogastric. So very important, make MCQ වලට බොහොම වැදගත් දෙයක් මේ කියන එක. Small bowel, large bowel diarrhea. So I hope everybody is looking at slide 17. I'm sorry for the problem today, but in the little technical problems, right? So 17 that is very important. Now go to the next slide now. Slide 18 right. Now slide 18 gives a different clinical approach. So this first clinical approach was small bowel, large bowel. The table number 2 in slide 18 gives you a different approach. It goes mostly on the mechanism of diarrhea. So another way of categorizing chronic diarrhea is based on the mechanism of diarrhea. So ඒ වගේ mechanism පහකට බෙදෙනවා. Secretory diarrhea, right? Secretory diarrhea, lots of water. ඒක ලියා ගන්න ඔය secretory chronic diarrhea ගොඩක් endocrine problems වල ඔය hormone secreting tumors like VIP, carcinoid, so serotonin ඔය වගේ ඒවා secretory හොඳාම secretory diarrheas, right? Secretory diarrhea, and the important thing, fasting does not alter the diarrhea. Secretory. So you see this often in this sort of neuroendocrine tumors that secrete VIP, serotonin, or gut tumors. Right. So that is one. Osmotic diarrhea, for example, you take osmotic laxatives, that diarrhea you get is osmotic diarrhea. Right. Chronic diarrhea can be inflammatory, especially those associated with inflammatory bowel disease. Blood තියෙන්න පුළුවන්, mucus තියෙන්න පුළුවන්, features of inflammation තියෙන්න පුළුවන්. Right. Malabsorptive chronic diarrhea is commonly due to distal ileal disease. All the features, steatorrhea, distal ileal disease. Right. Chronic diarrhea can also be due to autonomic dysfunction or dysmotility. Right. The autonomic nerves prashna, and that commonly, like for example, like diabetes, diabetic autonomic neuropathy in the gut, that causes more of a nocturnal diarrhea. So this is a very oversimplified maybe approach to chronic diarrhea clinically. So you can categorize it clinically based on the site of the chronic diarrhea, which is in slide 17, or you can categorize it based on the mechanism or the pathogenesis of the diarrhea into secretory, osmotic, inflammatory, malabsorption, and dysmotility. Hari. Eka බලන්න දැන් හරිද කියලා. Any questions up to now? So somebody is asking, can we diagnose Helicobacter pylori by endoscopy without a biopsy? No. The answer is no. You can't. You need some sort of test in that, like a flow test. Hari. Any other questions about chronic diarrhea, acute diarrhea? And I will discuss, go to slide 16 so that we can discuss that now. Slide 50, yeah, question number 5, on slide 16. So let's go through the statements here. First statement. Frequent passage of large volume water is to large bowel pathology. Then the frequent passage of large volume water issue is actually more towards a small bowel problem. There's a lot of water in the small bowel. Because small bowel is side that absorbs the water. So there's a lot of water in small bowel. Steatorrhea suggests pathology cecum nevi. Steatorrhea I specifically told you is associated in distal ideal disease. That's where the fat is absorbed. Right. Pancreatic calcifications indicate the possibility of malabsorption as a cause. Yes, because you can in chronic pancreatitis because of deficiency of digestive enzymes. That can call a very similar steatorrhea-like picture. Fasting reduces the frequency of secretory diarrhea is false. Secretory diarrhea is due to this hormonal neuroendocrine tumors that secrete various hormones like VIP, serotonin. Fasting does not alter the amount of frequency of diarrhea for secretory diarrhea. Right. The last one we will discuss with the next Crohn's disease. Right. And now move to slide. Yeah. Move to slide 6 now. Slide 6, sorry, slide 19, question 6. Now here I have given you an MCQ on irritable bowel syndrome. Irritable bowel syndrome MCQ. Right. Now, irritable bowel syndrome one, irritable bowel syndrome is a diagnosis of exclusion. Right? It is a diagnosis of exclusion. Irritable bowel syndrome can present sometimes with chronic diarrhea. Can also present with constipation as well. So, diarrhea cannot pull on, constipation and cannot pull on. Or sometimes you get a mix of constipation and diarrhea. Mix cannot pull on. It is, but remember, it is always a diagnosis of exclusion. You need to exclude all the sinister pathologies like cancer, small bowel, ulcerative exclude. You can diagnose IBS. Very important. Go to slide 20 now. Slide 20. So IBS is diagnosed on something called the Rome 4 diagnostic criteria. Definition. Right? Various definitions. Stool types. But essentially, it is a nice clinical definition. IBS. Right? Okay, and as you can see, it can cause diarrhea, constipation, or mixed. Right? Go back to the question 6 then. Now remember, irritable bowel syndrome is commonly associated with various sort of psychological comorbidities also. Right? Psychological comorbidities. And things like fibromyalgia. Right? And if you look at the pathogenesis of IBS, association with a past history of bowel infection, right? So history of acute enteric infection is a recognized risk factor. So there is evidence to say that there might be an association with severe enteric infections in the past. Now, remember, and again, I emphasize the fact that IBS is a diagnosis of exclusion. So if there is weight loss or something, you cannot diagnose it unless you exclude a malignancy. So in IBS, you don't get weight loss. There is no nothing to suggest an alternate cause. It is a diagnosis of exclusion. So weight loss, no. Irritable bowel syndrome, weight loss. Right. Now, if you go to slide 21, Ramai, that gives a sort of list of the drugs which are used in the management of IBS. And remember, in IBS, behavioral non-pharmacological strategies are quite important. Right? And certain dietary modifications like lactose restriction, high fiber diet, gluten restriction, FODMAP diet there is a special set of food that you call a FODMAP diet, low FODMAP diet. Right? So a lot of dietary behavioral modifications are done, right, in IBS, and also use a lot of things like antispasmodic agents, antidepressants, loperamide, right? And depending on whether it's constipation or diarrhea, these are some of the agents that you use. SSRIs පාවිච්චි කරනවා, loperamide පාවිච්චි කරනවා, right? ඒ වගේ drugs අපි පාවිච්චි කරනවා. And probiotics have also been used to good effect in IBS. හරිද බලන්න ඒ ටික ළමයි? Right. Okay. Right. Hari. So let's move on to slide number 22, which is a very famous sort of thing, which compares. So we are going on to inflammatory bowel disease now, lamai. Inflammatory bowel disease anime. So inflammatory bowel disease is a very complicated topic. At an undergraduate level, you need to know the differences between Crohn's and ulcerative colitis. Okay? Now go to slide number 23. I have sort of summarized the key points, the key differences, right, between Crohn's and ulcerative colitis in this slide. Make MCQ වලට වැදගත් දේවල් ටික මම කිව්වොත් එහෙම මෙන්න මේක. හරි. There is evidence to say that actually smoking might prevent ulcerative colitis, right? Again, negative association එකක් තියෙනවා. Prevent කියලා වචනේ පොඩ්ඩක් සැර වැඩි. Negative association එකක් තියෙනවා. Right? So smokers have a lower incidence of ulcerative colitis. පොඩ්ඩක් මතක තියාගන්න. මේ උඩ මේකේ, right? And family history is stronger for Crohn's disease. Stronger for Crohn's disease. හරි ඒකත් පොඩ්ඩක් මතක තියාගන්න. Stronger for Crohn's disease. හරි. And slightly maybe higher male in Crohn's. Slightly higher male predominance in Crohn's. Right. Now apart from these epidemiological katandara, the pathology of ulcerative colitis and Crohn's is different. නේද? ඒක ඔය slide 23 වල යට මම summarize කරලා තියෙනවා. ඔක්කොම ඔයගොල්ලෝ දැනගන්න ඕනේ histopathological changes and sort of histopathological plus macroscopic changes that you get. Pathological changes. හරි? Pathological changes ටික. Right. ඒතර මතකයි මේක නේද? Crohn's disease is a disease that can involve any area of the gastrointestinal tract. From mouth to anus, anywhere can be affected in Crohn's disease. Anywhere can be affected. Right? And anywhere can be affected, plus the whole thickness of the bowel is affected. Transmural infarcts. Transmural involvement. The whole thickness of the bowel is involved. Right? However, so you get skip lesions. So the anywhere from mouth to anus can be involved. That is important. Anywhere from mouth to anus can be involved, right? Transmurally, but there are skip lesions. Skip lesions, right? Skip lesions. And if you look at the mucosa, it is a sort of a cobblestone appearance. Cobblestone kind of parata gallallani. Cobblestone appearance. Cobblestone appearance, right? Cobblestone appearance. And because the bowel is transmurally involved, you can get fistulae also and stenosis of the bowel, right? Strictures of the bowel, stenosis of the bowel is quite common in Crohn's. And and you get a lot of granulomata on histology in Crohn's disease. So remember, Crohn oka hariyata ahanama, yeah. හරියට අහන ඕක MCQ වලට අහන්න පුළුවන්, surgery වලටත් අහන්න පුළුවන්, medicine වලටත් අහන්න පුළුවන්. So it's a quite different pathology, macro microscopic pathology that you see in Crohn's. Whereas ulcerative colitis is common in the rectum and the sigmoid colon, right? Rectum and the large bowel essentially. You can get a little bit of ileal involvement also in some people, right? Some people ileal disease ටිකකුත් එන්න පුළුවන්. Now compared to Crohn's, which is patchy involvement, this is continuous involvement, and the whole mucosa is erythematous and inflamed, right? Whole mucosa erythematous and inflamed. but mucosa එක විතරයි මුළු bubble wall එකම involved වෙන්නේ නැහැ. mucosa එක විතරයි ප්‍රධාන වශයෙන්ම you get involved. And a lot of inflammation, erythema, inflammation you see, right? Or crypt abscesses, pseudopolyps, all of these are inflammatory regions within this ulcerative colitis disease. So ulcerative colitis is essentially mostly the large bowel, rectal, sigmoid, and large bowel, little bit of ileal involvement, mostly a mucosal superficial disease, a lot of inflammation and erythema. Completely different to the ones I mentioned in Crohn's disease, which are transmural skip lesions, bowel strictures, the whole wall is affected. Whole wall is affected. Okay. Right. Now let's go back to question 7. Then it would slide right. Then true or false regarding the features that suggest a diagnosis of ulcerative colitis over Crohn's. Ulcerative colitis features blood and mucus diarrhea is more common in ulcerative colitis, definitely, because it is more inflammatory. It involves a large bowel predominantly and is a mucosal disease. Lots of ulceration, lots of inflammation. Lane or mucus, large bowel involvement. Right? So that is true. That is true. In Crohn's, you don't usually get blood, right? In the puluang, but blood and mucus is much more common in large bowel ulcerative colitis. Right? Extensive perianal disease is not a feature of ulcerative colitis. Anal disease is obviously much more, almost 100% seen in Crohn's disease, right? Perianal disease, mouth to anus, sonama tanaka, right? Transmural involvement with granulomatine histology, as I have told you, is seen mostly in Crohn's disease. Crohn's disease is mulu bittiya meyani. Enisa thamai itana bittiya thick venni, right? You get strictures, you get connections like fistula between bowel loops because the whole bowel is involved. So granulomata transmural involvement is mostly seen in Crohn's, not in ulcerative colitis. Toxic megacolon, toxic megacolon is because of the inflammation in ulcerative colitis, right? And commonly affects the colon, causes dilatation of the colon, toxic megacolon. Elevated ESR dekema enawa eka wen karaganna bෑ. Hari dekema enawa ESR එක වැඩි වෙනවා. So if you go back to slide 23, please get this into your head, the main differences between Crohn's and ulcerative colitis. Hari. Any questions?
So ulcerative colitis වල pseudopolyps අපිට pre-malignant කියලා ගන්න පුළුවන්ද?
නෑ. pre-malignant කියලා ගන්න පුළුවන්ද? That's a difficult question to answer. So pseudopolyps are essentially a lot of inflammatory areas. Probably you're right, but ඒක pre-malignant කියන වචනේ පාවිච්චි කරන්න පුළුවන්ද කියලා මට sure නෑ ඒකට. Right? These are not real polyps, but just inflammatory masses වගේ inflammatory areas, not true polyps. Both of these diseases carry a risk of bowel cancer. Hari? Both of these. Hari? Both of these can carry a risk of bowel cancer, but I think ulcerative colitis has a stronger risk. Hari? Stronger risk. Right. Okay. Jeevanta, Crohn's can also cause, So, yes, Crohn's can also cause bloody diarrhea, but much more common. Bloody diarrhea is much more common in ulcerative colitis. Right? Much more common. Hari. Okay, fine. So let's go to question number 8 then. It's slide 24 lamai. Question number 8. True or false regarding ulcerative colitis? Smoking is a recognized risk factor because the smoking again, there's a protective effect. Kela epidemiology. There is evidence epidemiological that smokers have less incidence of ulcerative colitis. Cobblestone appearance කෙනෙක් මම පෙන්නන්න slide 25 වලට ගියොත් එහෙම cobblestone appearance එක පේනවා මෙතන මේ cartoon එකෙත් තියෙනවා මේ පින්තූරෙත් තියෙනවා cobblestone appearance කියන එක. අර ගල් අල්ලලල් වගේ එක පේන්නේ. So that is mostly seen in Crohn's, not in ulcerative colitis. Now talking a little, this is ulcerative colitis. We payna me more superficial ulcers හැම තැනම very erythematous, right? Erythematous. So that පේනවා ඒක අපිට. Right, now a word about extra-intestinal manifestations of inflammatory bowel disease. අපි මේවා ගැන කලින් කතා කරලා තියෙනවානේ. Sacroileitis can occur as an extra-intestinal manifestation. Also, you can get other extraintestinal meningitis like anterior uveitis. Anterior uveitis. Erythema nodosum. Right? And this, if you go to slide 27, erythema nodosum wala pinturයක් තියෙනවා. Also, these ulcers are pyoderma gangrenosum. Pyoderma gangrenosum. ඒවත් එන්න පුළුවන්. In general, inflammatory bowel disease ඕනම එකක එන්න පුළුවන්. Right? So remember anterior uveitis, sacroiliitis, erythema nodosum, pyoderma gangrenosum, and one more is sclerosing cholangitis. Like a liver case, sclerosing cholangitis. ඒක මතක තියාගන්න. හරි. ළමයි මම 4 5 දැන් කතා කරනවා. ඔයගොල්ලෝ යන්න slide 28 වලට. Any questions up to now? So very important MCQ වලට differences between Crohn's ulcer. ඒක බොහොම වැදගත්. Epidemiological differences මම පෙන්නුවා ඔයගොල්ලන්ට. ඊට අමතරව මම පෙන්නුවා pathology, macroscopic, microscopic differences. And also clinically also there is a slight difference. Ulcerative colitis more common blood and mucus diarrhea. Crohn's වල perianal disease, anal disease commonly එනවා. And also small intestine එක ගොඩක් involved නිසා small intestinal diarrhea, steatorrhea ඒ වගේ දේවල් විතරම එනවා. Malabsorption features commonly, right? But remember, ulcerative colitis is not in the small bowel; it is most in the large bowel. Blood and mucus diarrhea ගොඩක් එන්නේ. වෙනස්කම් MCQ වලට ඇහෙන දේවල්. හරි. Right. Now, statement 4 and 5 in question 6, I will focus on here in slide 28 and 29. Slide 28, 29 බලන්න. Now, ulcerative colitis can sometimes present as this ASUC කියලා එකක් තියෙනවා. Acute severe ulcerative colitis. Acute severe ulcerative colitis. It's an emergency. It is a gastroenterological emergency. Acute severe ulcerative colitis. Right. Okay. Gastroenterological emergency kala. Okay. Right. Now, how you diagnose this is based on a criteria called true love and wit criteria. True love attara true love wage, wit WITT. True love and wit criteria එක තමයි slide 28 වල තියෙන කාට පාඩමින් දැනගන්න අවශ්‍ය නැහැ. But it is used to diagnose and prognosticate acute severe ulcerative colitis. True love and wit criteria. Sorry. දැන් ඔයගොල්ලෝ යන්නේ ඊගාවට slide 30 වලට. slide 30 වල x-ray එකේ තියෙනවා toxic megacolon එකක්. right? toxic megacolon එකක් තියෙනවා. ඒ පින්තූරේ x-ray එකේ toxic megacolon. So toxic megacolon is diagnosed based on the abdominal x-ray. right? Okay, diameter එක බලලා මනින්න පුළුවන්. හරි? diameter එක බලලා මනින්න පුළුවන්. right? So that is how you diagnose it. හරිද බලන්න ඒක බලන්න හොඳට බලන්න. So essentially ඕක අපි සාමාන්‍යයෙන් cut off එක ගන්නේ 5.5 centimeters 6 centimeters තමයි සාමාන්‍යයෙන් ගන්න. 5.5 to more than 5 to 6 centimeters වලට වැඩි නම් toxic megacolon diagnose කරන්න පුළුවන් x-ray එකේ. ඒතර ඔයගොල්ලෝ slide 30 බැලුවොත් එimhe x-ray එකේ හොඳටම පේනවා කන පැලෙන dilate වෙලා තියෙනවා. Right? Right. So what do you do in this? What do you do in this setting? මේ slide 29 වලට යන්නකො slide 29 වලට යන්නකො. So if somebody presents with acute severe ulcerative colitis, your treatment is essentially intravenous steroids. That is your main treatment. Intravenous steroids. Hydrocortisone or methylprednisolone IV. Sorry, that is your main treatment. Main treatment option. If it doesn't work, if the steroids do not work, IV infliximab is used. IV infliximab. Right? If that doesn't work, steroids, IV, hydrocortisone or methylprednisolone, එක වැඩ කරේ නැත්නම් infliximab. If that also does not work, colectomy surgery කරලා අයින් කරන්න වෙනවා බබල් එක. Right? Surgery total colectomy කරන්න වෙනවා. හරි ගියේ නැත්නම්. Right? So, we have 3 options තමයි අපි පාවිච්චි කරන්නේ for managing acute severe ulcerative colitis. හරිද බලන්න මේ ටික දැන් ළමයි. එතකොට ඔය මම ඩිස්කස් කරන්නේ ඕල්ග slide 24 වලට ආයි question 8. So, abdominal x-ray has no place in prognostication. No place නෙවෙයි ඒක අනුව toxic megacolon අපි diagnose කරනවා. The other prognostic clinical score we use is true love and wit criteria. right? How you treat acute severe ulcerative colitis is steroids, IV, infliximab or colectab. ඒ විදිහට තමයි treat කරන්නේ. සමහර වෙලාවට අපි cyclosporin උත් පාවිච්චි කරන එකත් උනා ලියාගත්තට කමක් නැහැ. හරි. හරි. Okay. මම හිතන්නේ best response MCQ තුනක් තියෙනවා. ලේසි ඒවා වැඩි කලබලයක් වෙන්න දෙයක් නැහැ. ඔය ටික තමයි ඉතින් gastroenterology කියලා තියෙන ළමයි. උට වැඩි දෙයක් නැහැ. Gastroesophageal refluxes, Helicobacter pylori, ulcers, ඔය chronic diarrhea, acute diarrhea, inflammatory bowel. ඔච්චරයි. ලොකු ඒරියා එකක් නෙවෙයි. බය වෙන්න එපා. ඒකේ වැඩි ප්‍රශ්න අහන්නේ නැහැ. Right. Question 1 is a very straightforward thing. Chinese කෑම කාලා diarrhea එනවා. This is usually due to Bacillus cereus. Bacillus cereus. And this is a preformed toxin. මම ආයෙ ඔක්කොම infection ටික කරනවා බය වෙන්න එපා. Infectious disease කරනකොට, but this is just අපි මෙතන GI වලත් මේ කතා කරනවා මේක. හරි. ඒතර bacillus එක දාන්නවා. Right? මේකේ කතාන්දරේ question 2 is also very easy. I hope you have done these questions before. So long standing gastroesophageal reflux, we've already discussed that they are high risk of adenocarcinoma esophagus, and the etiology is Barrett's esophagus. Right? Barrett's esophagus. Question 3, slide 33, blood and mucus diarrhea තියෙනවා. And if you look carefully, there is thrombocytopenia, red cell fragments. So what is this? And high creatinine, if I'm not mistaken. Urea වැඩි. So this is HUS. And මොකද්ද හැදෙන්නේ? E. coli නේ. E. coli of 157 කියලා අපි කලින් කතා වුණා. HUS හැදෙන්නේ hemorrhagic E. coli 157. Right. හිමංග අහලා තියෙනවා. Sorry. 5 ASA සාමාන්‍යයෙන් acute severe එකේ පාවිච්චි කරන අඩුයි. අපි දෙන්නේ සාමාන්‍යයෙන් IV තමයි. හරි. Mild episode එකක් නම් you can give that rectally, but most of the time we use IV steroids if it's severe. හරි. Acute severe නම් mild flare එකක් නම් ඕක පාවිච්චි කරනවා, but severe flare එකකදී අපි සාමාන්‍යයෙන් IV දෙන්නේ. IV steroids, infliximab or colectab තමයි කරන්නේ. හරි ළමයි. ඒ ටික තමයි තියෙන්නේ. Right? So gastroenterology lo uccara තමයි තියෙන්නේ, hepatology තමයි තිබලා තියෙන්නේ. So gastroesophageal reflux disease, peptic ulcers and Helicobacter pylori, acute diarrhea infection එක චුට්ටක් කර අපි තව දුරටත් කරනවා when we are doing infectious disease. Then chronic diarrhea වල clinical discussion එකක් අපි කරා, small bowel, large bowel කොහොමද, causes of chronic diarrhea, etiology අනුව කොහොමද differentiate කරගන්නේ. Then inflammatory bowel disease, differences between Crohn's, ulcerative colitis, IBS ගැන කතා කරා. And especially talked about acute severe ulcerative colitis. Any questions? I'm sorry, I don't know why, but sorry about that. Right. There are some extraintestinal manifestations that are more in ulcerative colitis for whoever asked that question. But ඒ ගැන වැඩි කලබල වෙන්න එපා. පොඩි වෙනසක් තියෙනවා එහෙ මෙහෙ. ඒක ගැන ලොකුවට කලබල වෙන්න එපා. Right, so things like sclerosing cholangitis are common, if I remember, in Crohn's, but there's only a very slight difference. Right? Few minutes.
So, inflammatory bowel disease is the commonest extraintestinal manifestation. Sacroiliitis.
That I will have to check. But I make offhand mataka nahe. Skin uveitis is common, so I'll have to check that and tell you.
Sir, මේ MCQ එකේ අපි ගත්තේ features regarding ulcerative colitis කියලානේ. ඒක එහෙම නැතුව අර factors more suggestive of ulcerative colitis වගේ කිව්වා නම් extraintestinal manifestations ගන්න පුළුවන්ද sir?
More suggestive of the. එහෙම අමාරුයි පියුමි කියන්න ටිකක්. දෙකේම එනවා ඉතින්. දෙකේම එනවා.
වැඩිපුර එකක එනවා කියලා නෑනේ sir.
සමහර ඒවා එකක එනවා වැඩිපුර, but ඒවා ටිකක් complicated. මොන රටේද මොන ස්ටඩි එකද බලන්න කියන එක අනුව වෙනස් වෙනවා. එච්චර නම් details ගන්න ගන්න ඕගොල්ලෝ.
Thank you sir.
Right. So some of those yes, disease severity එක අනුව there is a relationship between the extra intestinal manifestations. There is a relationship. හරි නේද එහෙනම් ළමයි? Sarangani, Sunday then?
Yes, sir, Sunday.